Hello, I'm Dr. Denise Milne, Executive Director of the Alberta Continuing Care Association, or ACCA. It is my pleasure to welcome you to our third episode of our podcast, proudly sponsored by Moderna. Today, we'll be continuing our discussion on preparing for respiratory illnesses for the fall and winter. If you missed part one of the series, I encourage you to check it out after this episode. And don't forget, next month, we'll wrap up the series with a conversation on enhancing respiratory health in long-term care with special guests from CPED. Today, we are so fortunate to have Dr. Vivian Ewa joining us. Dr. Ewa is a care of the elderly physician with Alberta Health Services in the Calgary Zone. She is a dedicated advocate for best practices in elderly health care, and she has won numerous awards for her work in this field. Her clinical practice includes consultations with the Home Care Geriatric Consultation Team and the Seniors Health Outreach Program for continuing care facilities. Additionally, Dr. Ewa works at Bridgeland Seniors Health Outpatient Clinic. Dr. Ewa is a clinical associate professor in the Department of Family Medicine at the University of Calgary. She's also the medical lead for Seniors, Palliative, and Continuing Care portfolio in the Calgary Zone. Throughout her career, she's contributed to several innovative projects, including initiatives to reduce physical restraint use in hospitalized elderly patients. Thank you for joining us today, Dr. Ewa. Much appreciated. So I have a number of questions I want to ask you, if that's okay. And I'm going to start with, if you could share more about your experience in the field of respiratory illnesses to let our audience know a bit about your background.
Okay, thanks, Denise. And so I'm going to share my experiences from a clinical practice perspective as well as a medical leadership perspective. So in my clinical practice, like you've outlined earlier, I work in continuing care, the spectrum of home care, where I do the geriatric consult team as well as continuing care facilities, so long-term care, supportive living, where I do the seniors health outreach program. And also my leadership is also within the continuing care spectrum as well. And so in that experience, yes, I am a frontline staff. I'll start by saying that. So I have had to manage acute changes in medical status due to respiratory viral illnesses. I've also had to respond to outbreaks at continuing care sites. And over the COVID-19 pandemic, I was part of the provincial working group that was tasked with developing programs, policies, resources to support continuing care sites through the pandemic. And so one of the things that I would like to share really about, respiratory viral illness. And so typically when we think about the symptoms associated with respiratory viruses, the first symptoms that come to your mind, of course, is that cough, the runny nose, the fever, the muscle aches, and those are typical symptoms, sore throat. But in continuing care, especially with the population in our continuing care facilities, where we have the frail older adults, we see atypical symptoms. And so not your typical cough and runny nose that a younger population or sort of a very healthy adult population will present, but certainly what we see is those atypical symptoms such as just a change in behavior, confusion, not their usual self, requiring more care, increased falls. And so those atypical symptoms are certainly things that we need to watch out for as healthcare providers, as family and friends or caregivers of older adults who are frail and who have complex comorbidity, immunocompromised, is that they don't present typically with symptoms. And so as we head into this, or as we are in this respiratory season, it's really important to watch out for those atypical symptoms, those subtle changes in behaviors, in mood, that might signal that the person that is being cared for is probably experiencing an acute, respiratory viral infection.
I think that's an excellent point, the atypical, because most of us wouldn't look for those kind of changes in one's behavior, right? It's just not something we would tune into because we're always expecting what we traditionally look for, the cough, the runny nose, maybe there's headaches, the exhaustion, but really it's much broader in the elderly population, and we all need to be very aware of that, right? Because that's playing into their health not feeling well and not being understood.
Yep. Yep. And just to follow up on that is when you think about our population, so our older adults, especially those within continuing care and facility-based care, is those with cognitive impairment, those who are living with dementia, certainly cannot communicate things like the headaches, the sore throat. They can't even communicate the not feeling well. And so sometimes that actually comes across as a change in behavior. Because if I can't tell you I'm not feeling well, then maybe I'm more restless, I'm more agitated, I'm pacing, so more uncomfortable, more sleepy, just those subtle changes. So really one of the things that I think, during the height of the COVID-19 pandemic, we really had to message not just family caregivers and healthcare providers, who care for older adults, is to look out for those subtle changes.
And is there much education in terms of respiratory illnesses, and in particular the atypical symptoms, happening in our system in continuing care?
So I know that during the early days of the COVID-19 pandemic, we certainly put out posters and information about these atypical changes to highlight the fact that, persons who have cognitive impairment or living with dementia cannot communicate some of those signs, and also to highlight the fact that older adults tend to present atypically with, infections as a whole. So a lot of communication happened during that time. And I know that in continuing care facilities, there's still a lot of that heightened awareness of if there's a change in status, to certainly screen for either a metabolic or an infectious cause for it. And I think that education or that learning from the pandemic has still filtered through. I took a quick look at the outbreak management guidelines, and I think I was pleased to see that sort of surveillance, heightened surveillance, watching out for persons who are not doing well. So staff still are being encouraged to look out for changes in in mood, behaviors, or any medical status that might hint at a respiratory virus infection, especially if there is an outbreak or if there are other close contacts in the building or they have come in contact with.
So just following what you're saying, as a strategy, do you think we should be pulling that information back up and sharing it? I mean, the year might have changed, but the dynamic has not changed, right? And so maybe we should pull that information forward through you and get that information out. ACCA can do that through their membership. We can work with the other associations as well to get that information out, because I think it's a huge piece of the puzzle for the elderly that are compromised.
I think that's a great idea, and I certainly would, support that, and happy to collaborate in providing that information that can be widely shared.
Okay, fantastic. So is there anything else, Dr. Ewa, that would help operators that they need to be aware of, whether they're in home care or facility-based operations, in terms of respiratory illnesses that you feel is important for them to know as well? Because we've come a long way since COVID, right? Like, we have a much better understanding, I believe, through the pandemic and all our learnings, right? But is there more information, any other tidbits of information that operators should be aware of from your experience?
Yeah, so I think you're right. We learned a lot, and I think organizations, operators as a whole, providers of care, I think, we learned a lot in the last few years, and I think a lot of those learnings we're still carrying through. And I think one of the things that we should continue to do is that, being prepared. So preparing for an outbreak, do we have a plan if we have an outbreak? What are we doing in terms of surveillance? What's our isolation procedure process and specimen collection? And again, preparing in terms of vaccination. So what's the plan for vaccinating the residents? What's the plan for vaccinating the staff? What we've seen over the years is that we tend to do very well with vaccinating our residents, that's persons who are in continuing care facilities, but not so much with our staff. And so getting ready with that sort of messaging and engaging staff in terms of the need to have their vaccinations when it's available. So I think those are some of the strategies. And also with regards to flu, what's our plan in regards to Tamiflu? And so have we gotten the required consents? Have we filled the required forms with the residents or their, substitute decision makers? And for staff as well. That's one of the things I know in the last few years that organizations struggled with is staff getting access to Tamiflu. So who gives that prescription? And I think over the years, what we've encouraged, especially in the last year or two, is really encouraging staff members to connect with their family physicians to get that prescription, especially if they are not vaccinated, but definitely having a plan to get their Tamiflu. So those are some of the things that, organizations can start to plan. I know that the Outbreak Management Guide by AHS was recently updated. I believe it was in August of this year. So what I like about it is really stating what the roles, not just of organizations, of AHS, of healthcare providers, those kinds of things are. Another thing, again, in terms of preparing for the flu season and potential outbreaks and what that impact will have on staffing resources. And so as an organization, how would we mobilize additional staff and how would we care for residents, especially in, say, your long-term care type A, continuing care homes, if you have, a high level of acuity on site, and especially with pressures on acute care. What's the plan to care in place? Do we have the resources to do that? Are we engaging the medical directors, the healthcare providers, the physicians, nurse practitioners in terms of how they will support acutely ill residents on site if needed? Because some of our residents will prefer to be cared for on site. And so do we have those resources? So I think there's a lot that organizations can be doing before the season, when we're in the season, and sort of even post-season is sort of reflecting on the learnings and what else, we could do differently in preparation again for another season.
Yeah, we had Michelle Charlesworth on our earlier podcast, and she spoke about the low vaccination rate among staff and the impact that would have on staff dealing with their elderly patients that are not well, and with the healthcare resource shortage of staffing and qualified staffing, it's trying to really put this forward into everybody's awareness that there's some tough months that could potentially come up if we don't put some strategies in place to safeguard residents and safeguard our staff.
Yeah. That's always the concern, when we get into this, the peak of flu season or respiratory virus season, is that, we have staff who are not vaccinated and in some situations are not allowed to work if you're not vaccinated. And that's just because of the risk. The whole idea of vaccination is to interrupt that spread, is to break the chain of transmission. And so the more people that are vaccinated, the better it is for not just yourself as a healthcare provider or a caregiver, but also for the residents and the persons, older adults that you're caring for. And so it does increase the risk if enough people that can and are eligible for vaccination are not vaccinated. So how do we increase the vaccination rate among staff? And again, it's really, communicating, one-on-one, things that we learned even from the pandemic is, debunking any misinformations and having honest, empathic conversations about whatever that reluctance is to have the vaccination. So I think it's the same strategy we adopt in terms of just one-on-one understanding where people are coming from. And a lot of times people are coming from a place where they've heard or have had unpleasant experiences. And so that one-on-one conversation is certainly one that we have to have.
Yeah, and I actually think that's a great strategy, the one-on-one conversation, right? Because it's trying to seek understanding as to why the choices are being made by that individual, respecting that, of course, and then working with it based on the environment that they're working with, right? And what other safeguards can be put in place, right? I think that's hugely important, and it's quite a really respectful approach to take. And yet you're still safeguarding the residents that are, have compromised health conditions too, right?
Yeah.
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 Yeah. It's a good conversation to have in an organization, and it's good to do it on one as well. Yeah.
Yeah.
So you're familiar with the Alberta Outreach Immunization Program Guide. And one of the things that we noticed is that there's an expectation that 80%, that there's an 80% vaccination goal. And my learnings from Michelle is a lot of people or a lot of operators may not be aware of either the guidelines that came out, I think, in June of this year, as well as some of the expectation around the 80% rate, plus the whole piece around the 3 visits. So an initial visit, the follow-up visit, which is really ideal.
Yeah.
But may not be possible given resource shortages. How do you see that sort of playing out?
So, I'm going to be honest and just say that I became aware of that guide actually just in the last week.
Yeah.
And I took some time to read about it. And I have to admit, it's really well written.
Yeah.
I like the fact that there's a well-defined roles, responsibilities for the individual stakeholders.
Yeah.
I mean, I think that's helpful. It really addressed some of the confusions that we had, at the peak of the COVID pandemic. So it's nice to see that well written, and it's nice to see that we've engaged partners like our community, our special pharmacists, and that can really support with vaccination. And I think to your point about, not a lot of people are aware about this. So, I'm just thinking about even physician colleagues or medical directors of care facilities, and certainly owner operators of facilities. So I think the task now is to have a communication strategy to ensure that this is widely known and widely spread in terms of that information. I had an informal conversation with one of our MOHs here about that target. And in her opinion, when you look at the 80% target for the residents in these facilities, that's a goal that can easily be met. And, and when I think about Calgary, and I'm just going to, because that's where I work and I live, I know that our rates for facility-based clients has exceeded 80% mostly. And so in her opinion, we wouldn't have a problem hitting those goals. I think where we would struggle is staff, like you've mentioned.
Yeah.
But I think for residents, mostly, I think, it's a reasonable target, and I think one that can be reached. But to your point about the awareness of this document, I'm not sure if there's a planned communication strategy, but I hope there's one. I see that it was finalized on the 1st of October of this year, so really about 10 days ago. So I'm hoping there's a communication strategy that is robust enough to engage owner operators, healthcare providers, and certainly all of the stakeholders that have been listed in the document. And, like staff who work in these facilities, the pharmacists, the indigenous population, and facility operators. So I'm hoping that happens. Here in the Calgary Zone, there's usually the owner-operator meetings, and I think it happens in other jurisdictions, and I think that's a forum that these guide can be discussed, and probably have the partners from AHS who are providing that leadership and oversight to actually speak to the expectations in that document.
Yeah, you're right. It's a very well written, a very thoughtful document. And I know from ACCA we'll do what we can do to communicate that out. But it's a really like step-by-step lovely guide. And it brings in sort of that, the pharmacist is brought into the system. Like they play such a big role today in healthcare, let alone continuing care, a very valuable role. And nurses need to be able to lean into pharmacy. It's a huge role, and it's the whole document is well put together. It just needs to, we want to help share it.
Exactly.
Okay.
Exactly. And one of the things I determined after reading that was to reach out to the medical directors here in my zone to say, hey, there's this document out there. And I think that would be one strategy too, is, have them engage with their owner operators in the organizations to say, are you aware of this document? And can we start to socialize it amongst the operational and the healthcare providers and the sites.
And then how do we can implement some of these strategies or all of these strategies to make everything successful regarding the respiratory illnesses, right? Yeah, for residents. Yeah. Okay.
Yeah.
Do you have any recommendations for the field that we haven't covered so far that you feel would be helpful to the continuing care sector?
I think it's really, I like the language of, personal protective measures that is being adopted, in regards to how that strategy for the respiratory viral season is to say that we have a duty, we have a role as individuals, and as healthcare providers and as providers of care to persons who are within the continuing care system. And so what are those measures? So things like, if we're sick, what do we do? If we're sick, we don't go to work, we stay home until we feel better. If there's a site that is on outbreak, what is it that is expected there? Promoting hand hygiene and people washing hands repetitively, because we know that the way that these respiratory viruses spread is really by that contact droplets. And so, high touch areas, which, you're going into person's home or even to a facility, the doors, the elevators, the phones, those kinds of things. So really promoting those hand hygiene practices. And again, finally, vaccination, and so the message around what does vaccination do and what's our responsibility. So yeah, for myself, it's, reducing the risk of me getting infection. And if I do, from protecting me from serious or adverse outcomes, and importantly, interrupting the chain of transmission. So personal protective measures is certainly a language that really resonates in terms of when we're messaging the things that need to be in place as we protect ourselves, as we protect our loved ones and friends and families, and as we protect the people that we care for.
That was wonderful. I really love your very practical strategies and understanding of how to break the transmission. I think it is so helpful. I think it's just a really good reminder. We all have responsibilities to make sure we're all safe, and here it is. And really quite simple strategies to employ to make sure ultimately our residents in continuing care are safe. So thank you, Dr. Ewa, for joining us today and for your valuable contributions to the continuing care sector. We want everyone, whether clients, caregivers, or operators, to feel prepared and empowered as we head into the respiratory illness season, and today's conversation is an important step in that direction. To our listeners, be sure to tune in next month for the final episode in this series, where we continue to explore how to prepare for respiratory illnesses in fall and winter with more insights from leading experts. Thanks for listening, and we'll see you next time on the Long-Term Forecast.